Hello, my name is Sam Ash. I'm an associate physician in the Division of Pulmonary and Critical Care in the Department of Medicine at Brigham and Women's Hospital and an instructor in medicine at Harvard Medical School. I'm here to talk today about the critical care management of the COVID patients, something that I think has been on a lot of our minds recently. I have no relevant disclosures or conflicts of interest. What we're going to talk about today are some general principles regarding the care of the COVID ICU patient. We'll talk briefly about what we're not going to talk about, just to be clear about what things are important and what things we can sort of leave to the side for the time being. Do a little bit of background about ICU patients and COVID in general, when we might think about admitting a patient to the ICU who has COVID, respiratory failure, thrombosis, and COVID-directed therapy. So if there's one take-home point to remember from this talk, it's that the key tenet of critical care of patients with COVID-19 or SARS-CoV-2 are the same as those for the care of all critically ill patients. I think all of us have been impressed over the last 6 months or so with the rate of publication and the rate of research that's been going on with patients with COVID. I think we've also been impressed by the fact that many of these patients are very sick, and all of us have been hoping that there is going to be some sort of silver bullet that we're going to be able to use to help these patients, or something that we can do that's different than our usual that might allow us to help these patients more. And I think, unfortunately, thus far, we haven't found anything like that. We haven't found any way in which these patients are dramatically different from our other very sick ICU patients, especially those with respiratory failure, which, as we'll talk about, is the primary manifestation of COVID patients' critical illness. I am going to touch on a few primary departures from standard critical care procedures. These are primarily, though, related to infection control and prevention and to some extent critical care capacity, and less related to the disease itself. I will talk extensively about respiratory failure and the manifestations of COVID-related respiratory failure and how we might manage that, although they're largely similar to our standard care of ARDS. And I just want to say, I think all of us, again, have been hopeful that there will be new and exciting therapies. And I would just caution everyone, as we're taking care of these patients now and unfortunately for some time in the future, that we need to carefully consider study design and analysis and context before we modify standard of care. And I'll touch on a couple of the large studies that have come out and where there are exciting developments, but where there are potentially areas that we should proceed with caution. So what are we not going to talk about? We're not going to talk about those things for COVID patients in the ICU that are managed very similarly, if not the exact same, as any other ICU patient. And this includes the topics you see here, especially sepsis, shock. And then even though patients with COVID who are in the ICU tend to have high rates of myocarditis, or may have high rates of myocarditis based on some preliminary evidence, and may have higher rates of things such as stroke, once they develop those, they're not managed any differently than any other patient who's in the ICU with those issues. And so for the most part, we're not going to touch on those today, so that in the time that we have, we can focus on the ways in which these patients are slightly different and focus on what makes them particularly ill. So just a little bit of background here. So the minority of patients who have COVID-19 require critical care. The majority of them have mild to moderate symptoms. There are a minority who have severe symptoms and a smaller minority who have critical symptoms. And I should say that to some extent, these numbers vary by hospital, healthcare system, and country. So hospitals, if we define severity of illness based on the level of care, hospitals that have higher ICU capacity, for example, Italy, might appear to have patients who have a higher level of care or need a higher level of care, as opposed to the countries, perhaps in the developing world, where there are fewer ICU beds available. But in general, a minority of patients with coronavirus develop critical illness, but those that do are quite sick. When they develop critical illness, they tend to develop critical illness at about 1 to 2 weeks into their course. So these are data from China that looked at the time from illness onset to severe illness. And what you can see is that in both survivors and non-survivors, the time until the development of sepsis and ARDS in particular is somewhere in that 1 to 2 week mark from the days of the illness onset, measured from the onset of symptoms or measured from the time that the patient had a positive test. And as I mentioned just a moment ago, the patients who develop COVID-related critical illness are very sick, and mortality estimates are very variable. And again, to a large extent, may vary depending on a hospital or a country's level of care or the ability for them to provide critical care. But the mortality estimates for patients with critical illness who have COVID range anywhere from the high 30% to 60%, and even some outlying estimates as high as 90%. The majority of those who die with COVID-19 in the ICU die of respiratory failure or some combination of respiratory and circulatory failure. I should say, though, that we don't have a lot of good long-term data. So we don't have a lot of great data in terms of what happens to these patients long-term. And many of the studies we're going to talk about are limited by the fact that the endpoints that they have are measured either at 15 or 30 days. And many patients are still in the ICU at that point. And so it's somewhat difficult to know what happens to patients in the longer term. So let's talk for a moment about ICU admission, when we should consider ICU admission. So a lot of the considerations around ICU admission for a COVID-19 patient are similar to those of any other patient who's in the hospital. They're driven in part by local resources and provider concern and expertise, as well as the need for intensive nursing care. So patients who, for example, have COVID-19, but also have diabetic ketoacidosis and need frequent glucose monitoring or close monitoring of their acidosis might need to go to the ICU in a place where there is not the ability to provide those intensive nursing care on the floor. In general, though, if we want to put numbers to things, patients who have respiratory distress, who have unstable work of breathing, despite using an oximeter at 10 liters per minute, we'll talk about an oximeter and what that is in just a moment, or a Venturi mask, are probably those that need to go to the intensive care unit. And obviously hemodynamic instability and the requirement of vasopressors, so hemodynamic instability after volume resuscitation. Talked about acidosis, and then other patient-related factors. So patients who have a high risk of deterioration because they have a lot of comorbid disease or other issues. So we'll spend a large portion of the talk today talking about respiratory failure, in part because, as we mentioned, respiratory failure is the way that many of these patients die, and it's the primary challenge that we face when we take care of COVID-19 patients in the ICU. The primary sort of type of respiratory failure that we deal with in these patients is hypoxemic. To some extent, we may see hypercarbia, but it's largely hypoxemic. And our challenges in managing respiratory failure are similar to patients, with the added challenge of infection control and prevention, as we'll talk about in just a moment. And then we also have to think very carefully about goals of care. We won't dive into great detail about this, but as many of you, not all of you, are aware, patients who have COVID-19 who are older tend to do worse. And I think that probably comes as little surprise to those of us who care for patients with respiratory illnesses in the ICU. But it's particularly striking in COVID-19, and we do need to think very carefully about whether patients who have severe respiratory failure who are older, how aggressive we might want to be, or they might want us to be, more to the point, when we're taking care of them and thinking about how we're going to escalate their care. In terms of what's available to us to provide oxygen to patients pre-intubation, we have the same tools that we have for other patients, but with these additional infection control and prevention concerns. Nasal cannula, Venturi mask, and non-rebreather mask do not appear to dramatically increase the spread of viral particles, nor does an oximeter. And oximeters come in two forms. They are essentially oxygen concentrators, and they improve the ability to deliver a higher concentration of oxygen for a same flow rate. You can see one on the right side of the screen. This is a pendant type oximeter. There's also a nasal mustache type oximeter, which appears the way it sounds. It looks like a small bag or mustache that's placed underneath the nose. And this, with the same flow rate, allows us to deliver effectively a higher FiO2. Let's talk briefly about non-invasive positive pressure ventilation, CPAP, BiPAP, and high-flow nasal cannula, because there have been some concerns about those in the COVID-19 population, especially related to infection control. So non-invasive positive pressure ventilation, BiPAP and CPAP, the concern in using this in patients with COVID-19 primarily relates to infection control prevention. I should note that, as with patients who have ARDS in general, patients who have COVID-19 who use BiPAP do not tend to do particularly well, and the majority of them end up requiring intubation anyway. So I think it's a very select patient population in which we might consider using BiPAP or CPAP in patients who have COVID-19. In general, we should consider using it for patients who use it at home, and for the same indications that we would use it for otherwise in the ICU. So patients who have acute pulmonary edema in the setting of heart failure, or who have a COPD exacerbation. I would not use it for patients who have sort of incipient ARDS unless there's a concern about goals of care and a desire to limit the use of intubation, and it's going to be used in a time-limited fashion. If we do use it, then we should strongly consider the effect it may have on the spread of viral particles. We must consider it an aerosolizing procedure, an aerosol generating procedure, and so patients need to be in strict airborne precautions, and we need to ensure a proper mask fit. And then there are some respiratory specific concerns that respiratory therapists should be familiar with, including the use of a dual limb machine and a HEPA filter without the so-called anti-asphyxia valve, which is often present on patients' home CPAP masks. We see on the right side of the screen is just an example of one of the studies looking at the spread of viral particles. And you can see there is some spread of viral particles. And we won't go through the numbers here, but there is some spread of viral particles, and it is higher in patients who are using CPAP. And I should note that it's not just dependent on the device, but it's also dependent on the severity of illness. So patients who have stiffer lungs, that is, patients who have more severe ARDS, have a higher spread of viral particles than those who have less stiff lungs. So there is some interaction there between the device used and the patient's illness. High-flow nasal cannula, again, is a useful tool in many patients, but again, we have to consider the risk to the healthcare worker and to other patients in terms of the spread of viral particles. It should be considered an aerosolizing procedure. And we can probably use it as in non-COVID-19 patients. There was this initial concern about whether we could use it at all, but we probably can. But we do have to very closely monitor the patient and the device. What you see on the right side of the screen is from that same study looking at the spread of viral particles in the setting of the use of high-flow nasal cannula. When you can see, this is an example where the high-flow nasal cannula, they've simulated it coming very slightly detached from the patient's nose or being slightly misplaced. And the sort of bright signal you see are viral particles spreading throughout the patient's room and environment. And so it's very important that if patients are on high-flow nasal cannula, then both from a medical and from an infection control standpoint, that they be closely monitored. It is a useful tool, as I said, and it can be a useful tool for delivering other adjuvant interventions, such as inhaled pulmonary vasodilators, but it's one that we just need to use with caution. The other thing that we might consider in these patients pre-intubation, it's something that we've considered in patients with ARDS previously, but has not really caught on until the era of COVID-19, which is self-proning, or having patients roll onto their stomach prior to intubation. There are good data from several small studies showing that this improves oxygenation both in ARDS in general and in patients with COVID-19, and you can see that in the bottom right of the slide, where you see the PaO2 to FiO2 ratio improving, that is getting higher when patients are proned compared to before and after proning. It can be used in any oxygen requirement, but the patient needs to be able to move independently, and obviously the patient can't have things such as spinal instability and other things that would preclude their ability to roll. We'd like for patients to do this for 16 out of 24 hours. That number is more theoretical than evidence-based, but based on some animal model studies and extrapolating from the intubated patients in ARDS literature, we think that longer is better. And I will say that in general, this is only limited by the patient's comfort. One thing to consider is as the patient deteriorates, whether you might want to stop this peri-intubation, as it is obviously requires that the patient be supinated prior to intubation. I'm not going to go into great detail about intubation itself. I think that's a talk unto itself. But I do just want to highlight that this is something that takes a little bit more time in the setting of COVID-19 because of the PPE that is required and because of the setup that is required. I would say that most hospitals now are very familiar with this, and most providers who are doing intubations, whether that's the anesthesiologist, pulmonologist, surgeon, whoever is doing the intubation, are for the most part familiar with this now. If you're interested, the Annals of Surgery has and anesthesiology have issued guidelines regarding this. But it is important to have the patient, if possible, in an airborne isolation room and use proper PPE. It's also important to limit the personnel in the room and to adequately pre-oxygenate, usually with a non-rebreather mask, and preferably not with high flow nasal cannula to avoid the aerosolization issue. In general, we use a video laryngoscope to do this, to try to limit the anesthesiologist or whoever the intubating provider is exposure to droplets. Okay, so mechanical ventilation. So in general, the management of patients with COVID-19 who require mechanical ventilation is similar to those who have ARDS from other etiologies. That said, I think it's important to review this quickly just because this is the primary way in which patients manifest their severe disease in COVID-19. So in general, ARDS presents within 1 week. This is ARDS in general, and this includes COVID-19, although it may be slightly delayed in COVID-19. And if you recall from the Berlin definition, it's defined by the presence of bilateral radiographic abnormalities and a P/F ratio of less than 300. And just as a refresher about the P/F, that's the PaO2. So let's just say that the PaO2 is 100 divided by the FiO2 as a decimal. So if the PaO2 is 100 and the FiO2 is 50% or 0.5, then the P/F ratio is 200. And it can't be fully explained by cardiac failure or fluid overload. The initial ventilator settings for patients with ARDS in general and including COVID-19 should be 6 mLs per kilo ideal body weight. That ideal body weight is based on patient's height. And then the respiratory rate depends a little bit on the severity of the patient's acidosis when they're intubated, but generally in the 16 to 28 breaths per minute range. There has been a lot of debate as to what the appropriate PEEP or positive end expiratory pressure should be in these patients and in ARDS patients in general. And in general, we've been starting at our institution at a slightly lower PEEP for patients who have a lower BMI and higher for patients who have a higher BMI, although this might vary depending on the patient's severity of illness and other factors, for example, whether the patient has other chest wall disease like graft versus host disease. Again, we won't go into this in great detail, but as the patient is established on mechanical ventilation, it's important to adjust the mechanical ventilation to optimize their oxygenation. And the primary tools that we do this are by manipulating the FiO2 and PEEP. And we can either do this based on the ARDS-NET tables that you see below. And so for any given FiO2, we can set a PEEP, or we can adjust it based on the patient's mechanics. And again, in the interest of time, we won't go through this, but a variety of mechanics can be used. The example that you see at the top right is from a Hamilton ventilator, where there is a tool called the PV tool, which looks at the relationship between pressure and volume. And this is something that pulmonologists, anesthesiologists, other ICU providers, surgeons, and respiratory therapists have been using pretty successfully in COVID-19 to manage patients' respiratory failure. The other important piece in managing patients' respiratory failure and managing the ventilator is the titration of tidal volume. And I'll just point out that this is one of the most important things that we can do for patients with ARDS. We went through relatively quickly a couple of slides ago, but as many of you are familiar with, the so-called ARDS-NET trial, which showed that lower tidal volumes are associated with better mortality in ARDS, remains one of the best trials in terms of showing benefit in the ICU population. One thing that's important when we're doing this is to measure the patient's compliance, measure how distended or how distensible their lungs are. And we do this by doing an inspiratory hold. And again, this is something that we can do in collaboration with our respiratory therapy colleagues to make sure that the patients are not over distended. And if they are, to adjust the ventilator largely by decreasing the tidal volume to decrease their distension. Briefly about refractory hypoxemia, in part because this is the primary challenge that we face in COVID-19 patients who are extremely ill. So in general, although there's no firm definition for refractory hypoxemia, we define it as a PaO2 of less than 75 after mechanical ventilation optimization at relatively high ventilator settings. If we can, we try to reverse any processes that are ongoing, for example, by using renal replacement therapy or diuresis to remove extravascular or vascular volume, optimize vent synchrony, perhaps with ventilator settings or deep sedation, and then the use of paralysis and prone ventilation, and in some cases, ECMO. A very brief word about inhaled pulmonary vasodilators. Anecdotally, they do not seem to be as effective in patients with COVID-19. However, I should say that there are some in vitro data that suggest that inhaled nitric oxide in particular may decrease the replication of the virus, although additional work is needed to further explore that. In terms of the evidence base, so in ARDS in general, both paralysis with cisatracurium, which you see on the left side, and proning, which you see on the right side, when done early in the course, have been shown to be associated with improved survival in ARDS and have really become mainstays in our therapy for patients with ARDS in general and with COVID-19 related ARDS. Very briefly about ventilator weaning. In general, ventilator weaning is as per the usual protocol with spontaneous awakening trials and spontaneous breathing trials when appropriate. When we do extubate these patients, again, we have to consider infection control issues and exposure of healthcare workers. And so limiting the personnel in the room and ensuring that they're using the appropriate PPE is important. And then if possible, limiting the entry into the room after the procedure. There's been a lot of debate about the role of tracheostomy in these patients. I would say that in a general ICU population, those patients who are still ventilated and have a tracheostomy at the time of discharge have a very high one-year mortality. 60% one-year mortality. And so I do think it's appropriate to, again, revisit goals of care in this situation. The guidelines regarding tracheostomy are evolving in general. Previously, the guidelines had been to wait until day 21 of the patient's illness or their COVID PCR was negative. However, that is changing and remains a little bit of a moving target. Just a word about a couple other issues that we face in the ICU with these patients, and one of them is thrombosis. There does appear to be a higher rate of thrombosis in COVID-19 critically ill patients compared to the general ICU population. This is one area where they do appear to differ. Because of this, our hospital and others have recommended higher DVT and VT prophylaxis dosing, which you see on the bottom part of the screen. And then because we've been finding and others have been finding that we have had a lot of occlusion of arterial lines, we've been using low dose heparin infusions in the arterial line to prevent them from clotting. But it is something that is different about these patients compared to the general ICU population. And finally, a word about COVID-directed therapy. And there are no FDA-approved therapeutics for COVID-19. The therapeutic that's gotten the most interest and has been the most exciting has been remdesivir. And in general, it appears to improve the time to recovery, especially in severe disease. And what you see on the right side of the screen is a histogram of disease severity at day 15 by treatment arm in the remdesivir randomized controlled trial. And you can see that there's a higher proportion of patients on the left who have recovery at 15 days who got remdesivir compared to those who got placebo, who are more toward the other side of the plot there. The remdesivir trial is an example of a trial that needs to be interpreted with caution. When the remdesivir trial was originally published, there were some issues with the statistical analysis relating to how censoring was looked at and the inclusion of death as censoring, which do limit the interpretation of the study to some extent. That said, I do think that it should be used in the ICU, and I do think there are data that suggests that it is beneficial, but I think it is an example of where we need to proceed potentially with caution with other studies as they come out. Otherwise, I think it's important to consider patients for clinical trials if they're available, and if not available, to consider the use of off-label anti-inflammatory agents, whether that's tocilizumab, anakinra, or steroids. So in general, the key tenets of critical care of patients with SARS-CoV-2 with COVID-19 are the same as those for the care of all critically ill patients. While the minority require ICU care, they do have a high mortality when they do require ICU care. And the primary driver of that high mortality is respiratory failure, which means that the proper management of ARDS is critical. Thrombosis does appear to be more common, and enhanced prophylaxis to be considered, and remdesivir may improve time to recovery, and hopefully other agents that are being studied will show benefit as well. References are provided here in case you are interested in reading more about this. And I'd just like to add that much of this information is available at covidprotocols.org, which is a site that we have been maintaining and trying to keep up to date with the latest COVID-related research, primarily related to ICU level care. Thank you so much.